as Dr. Ross, I know he's a big focal therapy guy in our community nationally, internationally. But I just want to ask a question since we're on a PET CTs. How are you using those in that setting potentially at this point when you have a patient for focal therapy? Maybe not even a 4+2, but let's say a 3+4 patient that you're looking at. Are you starting to order it in that setting?
Yeah,
and how are you?
It's a great question, and like obviously you're being humble. You're much more of a focal therapy expert than I am, but there are about 10% or so of MRI invisible lesions. There are lesions that are questionable on MRI, and when you do focal therapy, which is also emerging for intermediate risk patients in general, there's a question of if you do ablative technology to spare morbidity, are you missing cancer somewhere else and going to have an out-of-field recurrence for sure? We did a trial with the Blue Earth folks that make a post-luma PET PSMA to look at like how often in the favorable intermediate risk setting are we going to get actionable information like higher grade disease, higher extent disease. It's as high as like 25% of the time. That's not the rate of having distant lesions, but that's maybe 10% of the time. And certainly for my 437s, I use the PET to help guide me. And I found it valuable in some 347s. The problem is we still don't have a great idea. And there's another large registry, I think, coming out of the Lantheus folks that make Polarify. We don't have a great idea of intraprostatically, where now PET PSMA is expressed on microvasculature and inflammation can go up. We don't quite know exactly what we're looking at. And I've certainly seen PETs that are very helpful. And I've certainly seen PETs where I biopsy all these avid things that are nothing. And again, for our nuclear medicine guys and gals, there is still, I think, at our institution, figuring out how to read these and how to even give extra prostatic lesions scores, like prominence scores or whatnot, and in intraprostatic lesion scores. So we're running the risk. I'm with you. I do use it in these settings. It could become a little bit Wild West. I'm trying to look for a little bit more guidance. I can't remember the name of the trial right now that Lantheus is running, but they ran a really large trial that should be reporting out. And I think we'll get a better sense for that. And similarly, and then I'll be quiet for a while, but in the post radiation local disease recurrent setting, I'm always getting a PET PSMA to look for distant disease before doing a local salvage ablative therapy. And if the PET is negative in the prostate, I'm still doing a biopsy of that prostate to see if there's local disease, because we just don't understand.
And I'll just add, MRI of the prostate in that case is also very helpful.
Also very, very helpful.
In that, like post-radiation field.
And that's, I think, the theme of your original question. I don't think you thought we would expand so much, but the theme was imaging nowadays is MRI based, which gives you lots of anatomic detail, lots of information, does not involve radiation, and nuclear medicine PET-based, because we have these molecular-based targets, and it's going to give us, again, functional information. It's functional imaging. And the old stuff, bone scan, CT, it's really going by the wayside. And like you were saying, Dr. Wan, we're dealing with issues of capacity now and issues of expertise that maybe AI will help.
Yeah, this is a good discussion. We'll get more to advanced disease in a little bit, but focusing in on non-metastatic patients, what other testing are we doing? Any consideration of AI, gene expression testing to help make decisions in those, maybe unfavorable intermediate risk or high risk patients? Are you guys using those tests?
So we've been using Decipher a lot in our intermediate risk patients and high risk patients. It's a 22 gene array test, and we use it for prognostication. And in the past, we've been using it to decide on adding hormone therapy, especially to patients with radiation, and even using it to help assist on the timing of that or duration of hormone therapy. More recently, we started to use the ArteraAI test, and I'm interested to hear. Our experience is quite young with it. We have about 25 patients we've used it on. It's interesting because the validation studies, and I'll be interested to hear Dr. Ross's opinion on this, but validation studies demonstrated about a 35% positivity rate. And this is a test that helps the urologist and the radiation oncologist decide on if ADT should be added to the radiation plan. If the test is negative, it's been predictive to not help. And so our positivity rate's actually around 5%. I think the validation was around 35%. So there's a little bit of a discrepancy with our real world data compared to, and albeit a very small data set compared to what the validation is.
That's fair. Yeah, we talk about this a lot in clinics when I'm multidisciplinary clinics. It's predictive, so that's kind of the holy grail of a biomarker. However, it was a retrospective review of studies, and there will be more prospective data on Decipher coming out through NRG, I think 09 and 10, to see if that test is going to be predictive in the radiation settings. So, all important things. Any other thoughts from?
Yeah, I mean, I think, I'd echo some of it. We certainly, like for us three as surgeons, what we are mostly doing is mechanical, just removal of the gland. And so, Dr. Patel said it well, like, really it's more when we're thinking about biology, do we want to use hormonal therapy to, sort of augment a radiation response or something like this? Or we're thinking about layering on more therapy. And the more biologically active the tumor gets, the more we're going to be helped by either understanding it genomically or genetically. There are some recent data from Stampede, for example, and also from Charted, looking at docetaxel around gene expression, things like Decipher. And, as a surrogate for how things are happening at the gene level, maybe the artificial intelligence can kind of capture some of that and give a higher turnaround time and maybe even find features the genes aren't looking at as they express their, histologic phenotype. Our experience is very much the same. We've been using a lot of Decipher at Northwestern. We use it mostly for decisions about hormonal therapy or not. There's lots of prospective trials that we've been involved in, that you guys are involved in, that you mentioned, that still have to mature. ArteraAI is newer, as you mentioned, like they have prognostic and predictive ability. Most, if not all, the data has been from retrospective analysis. What I've seen kind of recapitulates what you said. Like, it seems not to kind of say you're going to respond to ADT in the majority of people. And in some of their data they've put out, I worry that it's good at finding bad actors that definitely need the ADT or definitely need treatment. And I wonder a little bit about, can it identify people that also need it, but they're missing like that, And I think time will tell. I think myself, for digital AI, I see a signal there. They have great synergy with the National Radiation Oncology Group, putting out data from previously completed trials. And there's certainly a signal. There's value in digital pathology. I don't know if I'm ready to make clinical decisions on it yet. And sometimes we'll use that test, or I'll see that test in parallel to what I've been doing for 5 years or so, that more is like battle tested. And I think that the future is very bright, particularly as maybe resources become more scarce. And I'm interested to see if it's going to be complementary or, can be replace one another. I don't know yet.
But clinically, it's the clinical factors that we're used to that are still driving your...
Well, the Decipher of this sample will drive some decisions for me. And, there's data, again, from retrospective, studies in the correct clinical context that I'll use all the time. For example, RTOG 0534, which is an early salvage trial. We're surgeons and we have a lot of people go from early salvage. And it was looking at like, well, if you're doing early salvage, are you going to do it with radiation to the prostate bed, radiation plus androgen deprivation therapy? Are you going to do it with radiation plus short-term androgen deprivation therapy and, radiate the pelvis? And there's some nice data from that follows up from an older trial, which was R2G 9601, that if your Decipher is low, you can likely omit the ADT in that setting and have good oncological outcomes. Now, those are both retrospective analysis of prospective trials.
Yeah.
But if I add that to a large compendium of series that are prospective series and real world registries that are saying the same thing, I feel better using it. When I see an Artera come through, I still don't know. I know when it's bad, we're going to treat, we're going to intensify. When the Artera comes by and says the person's okay, and particularly if I have discordant things, I don't know how to adjudicate that yet. And that's because the test is less mature. It's been well developed. It has more to develop, but it's less mature. So, I think that and again, this, what we're talking about is, for the folks out there that are listening, it's important stuff. It's every day in our practices. But a lot of it is like gravy. It hasn't yet got to, like you said, the prospective randomized studies that are phase 3. We saw some phase 2s at Astro recently, but they're phase 3, like guidance, like predict. Those we're still waiting for. So it's not quite the level of like saying for a guy with metastatic castrate-resistant disease, standard of care is you need next-gen sequencing, to look at your, this is all sort of helping us individualize treatment decisions, and it's getting towards that light. I certainly, I would say like over half of my patients get some of this advanced testing, but it's, it's not as in stone as like, you got to see if this guy can qualify for.
Right, yeah. So, yeah, I think those are all great points. I mean, hopefully we'll have some prospective predictive data on Artera at some point.